Thank you. I know everybody knows Professor Kamath. He's a professor of hepatology at Mayo Clinic. He's the father of the MELD score and now the father of the MELD 3.0 score. I'm proud to say he's from, we share alma mater, PGI Chandigarh. Professor Kamath will talk about assessment of liver disease prognostication from child CTP score to MELD. You can start.
Thank you so much, Srinivas, for inviting me. I see a lot of friends in the audience too. So I'm going to speak on history of prognostication of liver disease from CTP score to MELD 3.0 to beyond. So in this talk, I will go over why we need prognostic scores, what are the simple prognostic variables in cirrhosis, the current prognostic scores, MELD scores, and I'll go a little over the history of prognostic scores and MELD scores, and future directions, which I think are really important, and then some take-home messages. So first, why do we need prognostic scores? So anytime we have a risk score or a prognostic score, we're going to use it either as a clinical tool, a research tool, or a policy tool. So for instance, a clinical tool, we're using it to counsel patients, to make management decisions, and to optimize care. So generally, if you're thinking about this, use the original MELD score or the CTP score. You can also use it as a research tool, and that's why entry criteria into studies as an endpoint and to stratify high risk versus low risk. And then you can use it as a policy tool, and that is for liver allocation, and currently it's the MELD 3.0. So when we look at prognostic variables in cirrhosis, we know with liver disease is biochemical dysfunction, portal hypertension, and extrahepatic organ systems are involved. And so we have got multiple variables in here. For instance, ascites, encephalopathy, pressures tell us how much portal hypertension there is. So these are markers of the hemodynamic system, biochemical dysfunction, and extrahepatic organ system. So theoretically, you can use all these in prognostic scores. The problem is every time you add a variable, the model becomes more complex, and the increase in accuracy is very little. But once you need multiple variables for a model, and if you don't have one variable, then you cannot apply. So basic rule number one is if you're creating a model, and many of you can do this, just keep your models as simple as possible. Now, when I see a patient, I have very simple prognostic variables. When I see the patient, I look at their blood pressure. This is a very interesting study. Mean arterial pressure less than 82, no one survived for more than 4 years. So generally I say blood pressure of 100 millimeters of mercury and below, poor prognosis. Systolic blood pressure more than 100 millimeters of mercury, better prognosis. Not a great prognosis, but certainly better. So look at the blood pressure in these patients, simple variable. Look at whether they are compensated or decompensated. Compensated cirrhosis has a very good long-term survival. Decompensated cirrhosis, you're decreasing survival to about 1.5 to 2 years, and that is when you're going to be considering liver transplantation. And then what is now called further decompensated cirrhosis, that is a complication of a complication. So if you have ascites, now you have hepatorenal syndrome. You had variceal bleed, another variceal bleed. You have encephalopathy, now you've got refractory encephalopathy. That drops median survival to 9 months. So simple variables first at the bedside. One of the problems is endpoints are more predictable if progression is unidirectional. That is, all patients are going to get worse. However, increasingly, liver etiology will be treatable, and this will result in reversal of decompensation and regression of fibrosis. And so accurate endpoint prediction will be more difficult in the future. So let's go over the current prognostic scores and a little of the history as I was asked to speak here. You have to consider prognosis at the very first diagnosis of liver disease. You see a patient, you've diagnosed metabolic dysfunction associated liver disease. Very difficult to predict mortality, so you cannot do it at this stage. Once they have decompensated disease, they're getting complications, then that is where the MELD and CTP scores come on. Now, I know there are organ failure scores, but these are very late. So we know an organ failure score is very accurate because accuracy of any score is highest immediately before the endpoint. But organ failure scores describe the dying process. They don't predict mortality. For instance, if you look here, nobody's going to say, I predict Usain Bolt is winning the gold medal. What you're going to say is, he has already won the gold medal. If you've got 28 runs to make and only one ball, you already say they have lost. You don't say, I predict they would lose. So that is the problem with organ failure scores. Now, let's come into the history. That is the talk here. So this is a question. Think about this. There are 3 people on this list who are essentially unrecognized for liver prognostic scoring systems. And they've done the most important work for the prognostic scoring system. Just think about this. I'll give you the answer in a bit. Now, there are 2 on this list who are disproportionately recognized for liver prognostic systems. Is it Wants, Pugh, Child, Roger Williams, or Mary Ann Payne? Think about this. Answers coming up. These are the 3 who are essentially unrecognized. And I think among all of them, the most important were Wants and Mary Ann Payne. And probably Mary Ann Payne. Remember, she's a woman surgeon in the 60s. Women surgeons did not receive any recognition. And I think she did the most important work with George Wants on prognosis of liver disease. I'm going to show you her paper in a bit. And Roger Williams, of course, is behind the Pugh part of the classification. Again, a little more detail coming up. So these are the 3 who are essentially not recognized, at least their names are not recognized in the scoring systems. Who are disproportionately recognized? Pugh and Child. You know, Child is very prominent. You talk about the Child score. But really, he built up on the scores of Wants and Payne, and Jeremiah Turcott was his fellow who did all the work. Again, a little more detail coming up. So remember this in your prognosis. Look at this. What a superb paper. Wants and Payne. George Wants and Mary Ann Payne. New England Journal of Medicine, 1961. This is, Child score is essentially a copy of this score. Mary Ann Payne had A, B, and C as a group. She didn't call it class, she called it A, B, and C. Look at the criteria she used, still managed, almost identical. So the Child is almost identical to this, the operative mortality. And look at this. They were so clever. They knew muscle wasting is a problem. They thought muscle wasting was a problem. Child thought maybe muscle wasting is not a good term, and they used nutrition instead. Pugh was a resident with Roger Williams. Roger Williams had the idea. Pugh was the resident. This is the only paper he wrote. After this, he went to do private practice in Saudi Arabia and then in Africa. So Mary Ann Payne and Wants started the score. Child, but mainly it was Turcott, who changed muscle wasting to nutrition. Roger Williams changed prothrombin time from nutrition. That's all they did, but it Wants and Payne. So if you have to remember someone, if you owe prognostication, it's Wants and Payne. So that is Roger Williams. And Roger Williams always said he wished he had put his name first in this paper, because then it would have been called the Child-Turcott-Williams classification. And this is the CTP score. Now let's go to the MELD score, okay? And there's a little history here. So fellows ask me, they say, please give me advice for research. And I say, I cannot give you advice. The patient you're looking after is the best person to give you research advice, research ideas. If you look at the problem with a patient, you don't know how to solve it, that is your idea for research. Pick up something that you really like. So here's the MELD story. 1992, we started TIPS at Mayo. I joined Mayo in August 1991. I found that some patients were dying and some patients did not. I didn't really think about this too much. But then I remember this patient. She was a 50-odd year. She had lost her husband the previous year. She had a son, a little over 20 years. So the son and the mother were very worried about the TIPS procedure. And the mother asked, what are my chances of dying? The son asked, my mom die after the procedure. And the child was going, and I said, no, I think she'll do well. And unfortunately, she died 3 months later. So then I realized that whatever system we have of deciding whether they will do well or not was incorrect, or at least was suboptimal. So that is why I started a study to see, can we predict mortality post-TIPS in these patients? And so essentially for all of you, research is easy. Just think of the right question. Don't do research for the sake of research. Think of a question that is going to help patients and which clinicians want an answer to. Then everything follows, and you have to have collaboration. I had many collaborators, in particular Ray Kim, my fellow, my colleague, and one of the smartest people I know. Additional story, never give up, okay? You may have an idea, journals may not think it's a great idea. So here was the MELD paper. I asked my mentor at that time, Sid Phillips, to look at it. I asked him, where should I send it? He said, hey, TIPS is a new procedure. You have found a way to select patients for it. He said, send it to New England Journal of Medicine. They will like it. I sent it to New England Journal of Medicine, rejected without review, came back very quickly. Comment was, great question. We think it's a really important question, but they said this is a medicine journal. Your statistics is too complicated. All that modeling is too complicated. I said, okay, fair enough. So I sent it to, in our field, gastroenterology. Came back very quickly, reject without review. What they said was exactly the opposite. They said, your statistics is great, the mathematics is great, but we really don't understand why you did the study. They said you have to use TIPS only pre-transplant. I never understood this comment, but for you, I'm an editor of gastroenterology. Just know that we make mistakes, okay? So don't let an editor's mistake spoil your research career. So I sent it to hepatology. They rejected it, this time with review. Got very nasty comments from one of the reviewers. So he said, really, you think you're so smart and you can predict long-term survival? Because this model was for 2 years that we initially sent it to. And he said, by the way, just in case you don't know, hepatocellular carcinoma kills patients, not creatinine. I said, okay. Now I have to think of a way to get hepatocellular carcinoma out of it. So I picked 3 months. 3 months was the median time to transplant in patients on the waiting list. And 3 months I could, hepatocellular carcinoma no longer would come into the equation. So then I changed the paper completely, had an algorithm, and then I sent it to hepatology, and finally it was accepted after 2 revisions. So for all you researchers, never give up on an idea. Remember that. 2, editors make mistakes, okay? They've got other work to do. They may not read it as carefully. They make mistakes. If you think you have a good idea, send it somewhere else. Your paper will ultimately find a home somewhere. So as a result of the MELD score, it's become a metric for severity of liver disease, used for organ allocation, risk stratification and alcohol-related hepatitis, selection of patients for TIPS and surgery, and acute liver failure mortality risk, as well as variceal bleed mortality risk. So we can use it in different ways. Use the original MELD score for most patients only because it's been most validated there. So TIPS, alcohol-associated hepatitis, hepatic decompensation. For prioritizing patients for transplant, use MELD sodium. We've got little more experience with that, and MELD 3.0 is what we're coming up with now. But I want to spend a little more time on MELD from synthetic data, and that's going to be in the future. Now, if you want, you can write this down. This site is free. Anytime you have a patient, you can use this to calculate risks. For instance, post-tips mortality. You key in the variables, you can risk of mortality, talk to the patient about it. Prognosis in alcohol-associated hepatitis, we put in the variables and we can get 90-day mortality in here. So all this is on our website. For you, who are a lot of surgeons in there, so mortality risk in patients with cirrhosis, we key in the variables in here. Patient's age is important in surgery, INR, and then again, we get mortality risk. So we use this to counsel patients. What about mortality prediction in compensated cirrhosis, which I didn't go into? And you're going to be seeing more and more about these patients. This is a problem. We don't have an accurate score to predict mortality in compensated cirrhosis because at this stage, they're dying either of cardiovascular disease or cancer. But you can use the MELD score to predict risk of hepatic decompensation. Now we come into transplant. This is again part of the history. And many of you know this. Liver transplant initially was experimental, only a last resort procedure, more organs than patients. So there was no need of an allocation system. But then as people got better at transplant, the demand for organs outstripped the supply. So you had to have an allocation system. Initially, it was the UNOS system, which was really based on CTP score and waiting time. And that was changed in 2002 to the MELD system and 2016 to the MELD sodium system. So we're just trying to do better. And the MELD 3.0 and MELD sodium is really, this is the person, this is Ray Kim, my former fellow. No one understands models better than he does. So he has run with MELD and he has really taken it forward. So this is what we found. So this is a JAMA paper. This was found post MELD allocation, when it changed in 2002. Richer people were advantaged. So you can see blacks disadvantage versus whites. Before MELD, 50 times higher risk of mortality, 25% lower risk of transplant. But after MELD, equal chance of dying, equal chance of transplant. So it really helped disadvantaged minorities. The problem was females, and this is the work done by my colleague Alina. Pre-MELD, women had a slightly higher risk of dying, but post-MELD, even higher risk of dying. Unintended consequences. Lower risk of transplant pre-MELD, even lower risk of transplant post-MELD. So that's how Alina and all of us tried to get to work on this to advantage women. We thought one point to MELD would help women, but no one was willing to accept that until we came up with data that Ray Kim came up with, and this is a paper in gastroenterology showing that the MELD 3.0 is a little better than MELD sodium. Perhaps creatinine, which is what gives men an advantage. And let's see how this goes. But the problems, like I said before, no longer one-directional. Improvement in liver function and even regression of fibrosis is possible. And so predictive models are going to become increasingly less accurate in the future. So MELD, as we see it now, is going to become increasingly less accurate because patients are going to get better from reversal of cirrhosis etiology. So now what are we working on? We want simple and cheap AI-based models for accurate prediction of endpoints. So we first worked on AI-guided prediction. What did we want? A cheap tool. Patients should accept it, so possibly even do it at the patient's home. Wearable devices are very accurate, but extremely expensive, so we cannot use that. So the question was, can we use ECG as a prognostic tool, a simple 12-lead ECG as a prognostic tool in cirrhosis? And so this is the work done by my colleague Joseph Ahn, and he's done some of our other AI work, and he's got San Diego now doing his degree in informatics, and he'll join us back in January. So in cirrhosis, there are hemodynamic alterations, and those result in clinical outcomes. And ECG in patients with cirrhosis has prolonged QTC, low QRS voltage, decreased RR variations, and short TP to T. This is repolarization. So there are ECG abnormalities in patients with cirrhosis. So we developed this, what we call the A score, the AI cirrhosis ECG score. And what did we find? We can use this score at a threshold of 0.17. This is the score that we have. So 0.17 and above, extremely good. So just look at the ECG and you can say this patient has cirrhosis. You don't need anything else to say this patient has cirrhosis. See how accurate it is. Very sensitive and specific. AOC 0.908. This is interesting. As the score goes up, you find that the MELD is increasing. So more sick the patient is, the higher the score. And around MELD of 25 and above, it seems to plateau out. So just an ECG, that's all to prognose for prognosis. Additionally, interesting again, the score keeps going up. Then we transplant the patient. The score comes down to normal. Few years after transplant, starts going up again. Whether it is recurrent mast cell or recurrent disease, we don't know. It starts going up. So we said, okay, now we can diagnose cirrhosis. Can we predict who is going to have complications? Again, extremely good. This time is a threshold of 0.25. So we use just ECG. The AI system will say, okay, this patient is going to have decompensation. When you add on for MELD, it becomes even more accurate, but by itself, very good. So here, look at the score. I told you the score 0.17 to diagnose cirrhosis. If we look at a patient with this score, we'll say 5 years, this patient will be alive. Let's say the score has gone to 0.25 to 0.5. We'll say this patient in 5 years has a 40% risk of mortality. And if the score is 0.75 to 1, we'll say in 1 year, this patient has a 50% chance of dying, and in 5 years is unlikely to be alive. All just from a single 12-lead ECG. So we said we have to validate this. So we work very closely with the University of Barcelona liver group. And in that team, it's not doing that well. It's still good. Still a clinical tool, but not as good as in our system. So the AI machine has to learn. So this is what we are working on. So at Mayo, we have this. So when we click on the ECG, this is our cardiology people help us with that. Just on the ECG, we can make various diagnoses. The ECG is extremely accurate. It can give the age within 5 years. It can tell you male or female, 95% accurate, only from the ECG. Interesting, in cirrhosis, it makes the patient older than the patient actually is. And so here are some sort of examples in here. Here's a 41-year-old patient who decompensated with autoimmune disease. Score was low. When she decompensated, score went high. This was even more interesting to me. She was a 70-year-old female with cirrhosis. MELD score was only 10, but she was doing badly. And you can see her ECG score was much worse than her MELD score. So ECG is adding on anything. Here's a patient with biliary cirrhosis, 21 years, high score, transplanted, score comes back to normal. So ECG-based scores are impressive. They can predict liver disease severity, complications, and mortality over time. And we're still trying to do a little better before we can use it. Meanwhile, Joseph Ahn is working with us for synthetic data. So synthetic data is a mathematical algorithm which learns the patterns and translates into a real-world data set. So let's look at this. Trying to make it simple here. These are called diffusion models. So here we take a dog, take all the data and destruct the data. We keep adding noise till eventually it's only noise. You take noise and it's called denoising, and we come up with another dog. This dog has all the characteristics of this dog, but it's not identical. So if I have all your pictures, we can come up with a list of people who look almost like you, but not you. So this is called synthetic data. So this is the UNOS data list of 38,000. We came up with a cohort of 38,000. Notice the synthetic data are almost identical, almost identical. Look at the gender, dialysis, wait list. This is synthetic, all de-identified. We find survival patterns of the real data and the synthetic data almost identical again. So UNOS data original, median survival 110 days. In our cohort, it's 101 days. Transplant-free survival 22% at 5 years, 22.8%. So we know this is extremely accurate. It preserves the MELD performance. So why is this important? Why are we making such a big deal out of it? This is why it's important. Currently, let's say you have a patient with MELD 3 of 35, we can predict mortality. But remember, it may be a little different if it is creatinine-driven mortality, sodium-driven mortality, INR, bilirubin. It depends on the age. So all these variations are in there. So for instance, someone my age will have a much higher mortality than someone who's 35, even if they have a higher identical MELD score. So with this synthetic data we have, we can say this patient, this is exactly what this patient's survival is. So we can predict the individual patient's mortality now. And this interval is what's called nearest known neighbor, which means patients who look almost identical like this is going to be their mortality. So I think this is the future. So my take-home message is, at bedside, look at the blood pressure, patient compensated or decompensated for prognosis. If you want broad stratification, use the CTP score. If you want finer stratification, use the MELD score, the MELD sodium and MELD 3.0 for organ allocation. But for the future, I think synthetic data is likely to be the basis for organ allocation. Thank you.
Thank you, Professor Kamath. That was a very interesting talk, actually taking us through the history of prognostication. Any questions from the audience? Dr. Mathur.
Dr. Kamath, this was a wonderful talk, and it's so great to hear the entire history of how this came about, and also important to set the record straight, I think. I had a question about your last point about synthetic data. One of the challenges with AI anywhere is that the outcome is only good as what you're putting into it. So I guess the synthetic data you have is really good based on whatever variables we think are important currently. So how do you make synthetic data smarter than data is right now? How do you make it MELD 4.0?
So I think that's a very important question. So your database has to be perfect. So we have the UNOS database, so our synthetic data is on the UNOS database. We have another large cohort of patients with alcohol-related hepatitis, so we have synthetic data on that. So in the alcohol-related hepatitis, the reason we're using synthetic data is anytime you do a study, you need a control group. The control group may not be identical to the patients being studied, and patients don't want to enter into a study where they might be in a placebo. So the FDA now approves synthetic data. So we have a cohort of patients whom we know what they would survive without treatment. Now we start treatment. We pick what we call nearest known neighbors. If you're doing better than that, then we know the drug is working. If you're doing worse than that, you're having side effects. So for organ allocation, all we can do is work with the UNOS system. What we have to try and do is work even better on the UNOS system. So if the broad question is, can we use this synthetic data for people in India? I don't know. I don't believe so. but it depends on exactly how you do it. So unless you have a very good data set, you cannot. We believe at Mayo we can do this because we have follow-up from almost from birth to lifetime, so we can use that. Outside of that, these will be difficult to use. So outside of UNOS, I think we'll have problems. For studies, for trials, maybe. And also, for allocation, one of the problems is it's called synthetic data. No surgeon, when I talk to my surgeons, they say synthetic. They're very skeptical once you say synthetic, okay, because they think it's fake.
Prof, just a question. I mean, how did you decide to use an ECG for getting to run on AI to predict? I mean, what was the thinking behind using an ECG and not? I mean, I don't know maybe something else that probably more similar to what liver function is then.
So at Mayo we have it's a sort of lounge. It's a coffee room where you come down for coffee. So people from different specialties meet there. So we meet a lot of different people. So there were cardiologists. So there's Doug Simonet, who is my fellow and then a consultant. We were talking to the cardiologists who have this ECG model. You take an ECG, they'll say, what's your chance of getting cardiomyopathy in 5 years? What's your chance of atrial fibrillation? Now they do it in every patient who's pregnant. At pregnancy, you do an ECG, you can predict whether they'll get postpartum cardiomyopathy. Then you can change things. So we were saying, hey, in cirrhosis, there are a lot of ECG abnormalities. Let's look at it. So they had the algorithm. They had all the devices. Most important, they had the money to do all this research. We didn't. We just gave them the idea. And now it turned out really good. So it's essentially we borrowed somebody's idea. And you need collaboration across things. I think physicians in India are the smartest, the engineers the smartest. If we have IITs, the medical institutions collaborating, we can do all this even better.
Patrick, hi. It's Mohammed Rilla here.
Oh, of course.
How are you?
Good, how are you? I enjoyed your talk, by the way.
Thank you. Oh, fascinating talk. I really enjoyed it. I mean, every time you give
touch, which AI does not have, I think patients like that. Last week's New England Journal of Medicine has a really nice article on AI in education and how we use it. So here's the problem. Let's say we use conventional, we find something went wrong. You looked at all the data points that you did your examination, something went wrong. You can go back. You can see which lab you missed, which X-ray you missed, get the diagnosis. With AI, if you're wrong, we don't have a way of retracting to find out where we made the mistake. So until we can get AI to a level which can go back and tell us where we can do better, I think we'll have a problem. So AI has to help us, it cannot replace us.
Patrick, the time is for inauguration, and we've got the VIPs who have arrived here. Please do stay on, and thank you very much for your wonderful talk. Is that okay? Is there anything else?
No, nothing more from my side. Thank you.
Thank you.
And again, thank you, Srinivas, for inviting me.
Thanks a lot, Prof. Thank you for coming. Thank you for coming online and giving this excellent lecture. Thank you.